Today, we are undertaking a truly comprehensive deep dive. We're dedicating the entire time to the engineering marvel that is the shoulder girdle and the arm.
It's it is quite simply the ultimate blueprint for balancing just extreme mobility with very precise stability. You
Correct.
might look at the shoulder and just see a simple ball and socket joint, but the sources we've gathered, they show a meticulously engineered kinematic symphony. It's beautiful.
A symphony, I like that.
It is. The upper limb has to handle these complex patterns of stereotactic movements. That's, accurate spatial positioning. And it has to do that alongside a crucial stereognostic function.
And stereognostic is the ability to recognize something by feel, right?
The ability to recognize an object by feel alone. And the thing is, if you can't position your hand accurately and steadily, you can't feel, you can't manipulate. The whole system fails.
That sets the stage perfectly. So our mission today is to trace the system from its foundational bones through every single stabilizing ligament, every connecting nerve.
All of it.
And ensure we don't just list facts, but really understand the why behind the anatomy. The central paradox we're going to be confronting today is this. The shoulder joint is inherently unstable. It's built that way.
It fundamentally sacrifices that static stability for a massive range of motion.
So we need to understand the precise and often counterintuitive mechanisms like the coordinated muscle action of the rotator cuff that dynamically keep the system together, prevent it from dislocating every time you reach or throw or lift something.
Yeah.
So let's start by looking at that core functional requirement.
The overarching functional imperative of the upper limb. It's really defined by its ability to reliably position the hand within what we call the object field.
The space where we interact with the world.
The space where we interact, exactly. This necessitates profound degrees of freedom and mobility. But, and this is the key, mobility alone is completely useless. Once the hand is positioned, the entire proximal system, the shoulder, the scapula, it has to be endowed with enough stability so that the hand can actually perform fine manipulative tasks.
Like signing your name or holding a tool steady.
Precisamente. So stability is a dial that has to be constantly adjusted.
And the sources introduce this vital concept of joint stability points. How do those extremes really define the limits of its function?
Well, we can define two functional poles. First, you have the point of instability. This is where the joint has a really high range of motion, the supporting ligaments are lax, and stability is minimal.
So it's depending almost entirely on muscle tone at that point.
Minimal resting muscle tone, yes. Think about holding your hand relaxed, close to your body, or making a tentative, unweighted reach. Minimal energy is expended, but the joint's integrity is low.
And the counterpoint to that is the point of maximum stability. This is where the system just locks down.
Exactly. Maximum stability occurs when the range is intentionally restricted, usually at the physical limits of movement, or, and this is critical, when the joint is loaded for weight bearing.
Like leaning on your hand or carrying a heavy bucket.
Exactly like that. And this maximal lock is achieved in what we call the close-packed position.
Okay, let's zero in on the biomechanics of those positions because they really define the risk of injury, don't they? So in the close-packed position, the joint surfaces, they achieve maximal congruence. They fit together as tightly as possible. What's happening to the soft tissues then?
In the close-packed position, you get a mechanical lock or compression of the bones. And at the same time, the major ligaments surrounding the joint become taut, they get twisted, and that maximizes the passive stability.
So the body isn't using muscle energy to hold it there?
Very little. This position often occurs at the extremes, for instance, full extension of the elbow or maximal external rotation of the shoulder. The joint is passively secure, so it minimizes the need for active muscular holding.
Conversely then, the loose packed position is where ligaments are slack and movement is at its maximum. So what does that mean for energy use and, I guess, vulnerability?
Well, when you're in that loose packed position, while movement is easy, the joint is intrinsically vulnerable. Stability is entirely dependent on sustained active muscle effort.
Ah, so that's where the strain comes from.
That is precisely why chronic strain and early degenerative conditions, specifically osteotendinous degeneration around the glenohumeral joint, often arise. It's when high external loads are applied while the joint is in a loose-packed, low-stability configuration. The system is always balancing energy conservation, which is loose-packed, against structural integrity, which is close-packed.
Okay, that makes perfect sense. So moving from the joint mechanics to the enveloping soft tissues, we have to address the deep fascia first.
We do. This dense connective tissue layer is crucial. It's not just a wrapping, it's a definer of function. While it's remarkably dense and pretty rigid in the lower limb, in the upper limb it forms the deep fascia of the arm, or the brachial fascia.
And the functional consequence of that brachial fascia is that it's not just a layer, like you said, it's an attachment site and a structural divider.
It is. The brachial fascia provides firm, defined attachment points for muscles, most notably the broad insertion of the deltoid. But more importantly, it sends these projections, the medial and lateral intramuscular septa, down to the periosteum of the humerus.
They basically fuse with the bone.
They do, creating these fixed, bony fibrous sheaths. And these sheaths are what define the functional fascial compartments of the arm. You have the anterior flexor compartment and the posterior extensor compartment.
The moment we start talking about fixed compartments, the major clinical concern of compartment syndrome comes into sharp focus. Can you elaborate on the anatomical basis for that? It's a life-threatening condition.
It is. Compartment syndrome is a consequence of volume change within a fixed boundary. So when you have high-energy trauma or severe burns or crush injuries, that causes significant hemorrhage or edema swelling within these fixed fascial compartments.
The pressure just skyrockets.
It rises exponentially. And since nerves and blood vessels run through these compartments, the increased pressure occludes venous return first, and then eventually arterial flow. This rapidly endangers the viability of the muscles and the nerves contained within.
The sources mention it's more common in the forearm and the leg. Anatomically speaking, why is there a difference compared to the arm?
It's a good question. The forearm and the leg naturally have more compartments and generally tighter fascial sheaths, which just makes them inherently more prone to these dangerous pressure increases.
But the arm is still vulnerable.
Oh, highly vulnerable, especially after major injuries. The standard clinical treatment is an immediate surgical fasciotomy, literally cutting open the fascia to relieve the pressure to save the muscle tissue. We should also mention the lesser-known but still insidious condition of chronic exertional compartment syndrome.
That's something you see in athletes.
Yes, it happens when muscle volume temporarily exceeds the fascial capacity during strenuous activity. It's much rarer in the arm than in the lower leg, but it's a real concern.
Okay, shifting our focus to the surface now, let's look at the skin's sensory supply. The figures in our sources showing nerve loss are a great diagnostic guide. So what does a clinician immediately look for to pinpoint, say, a root versus a cord lesion?
Understanding that cutaneous innervation map is absolutely vital for localization. If you observe sensory loss covering the lateral shoulder and the upper arm, you're looking at a classic C5 dermatomal pattern.
Okay.
Now, if the loss is greater and extends down the lateral forearm, you likely have a more severe or extensive lesion involving C6. Critically, sensory loss that results from a complete interruption of the lateral cord of the brachial plexus will affect the lateral forearm and the lower lateral arm, which tells you the lesion is proximal to the peripheral nerves.
And what if the sensory loss is centered on the posterior aspect of the arm, the back of the arm?
That points directly to the posterior cord and its terminal branches, like radial and axillary nerves. The skin over the upper limb is complexly fed, The supraclavicular nerves supply the top of the shoulder.
Yes.
The lateral cord feeds the lateral arm and forearm via the musculocutaneous nerve. The medial cord handles the medial side, and the posterior cord supplies the back of the arm. Identifying these distinct sensory zones is often the very first step in a neurological diagnosis after trauma.
So, last on the soft tissues, let's explore the redundancy in the skin's vascular supply. Beyond the major trunks, what is the key anatomical feature that dictates the viability of, say, a skin graft or a flap?
Well, the major trunks, the supraclavicular, the thoracoacromial, the circumflex humeral, and the ulnar collaterals provide the bulk flow. The critical surgical insight lies in the microscopic connections. These are the fasciocutaneous perforators.
That's a great term. What exactly are they?
Well, as detailed in some of the seminal work on this, these are small vessels that originate from the deep muscular or septal arteries, and then they pierce the deep fascia to provide direct, dedicated blood flow to the overlying skin.
So they're like a dedicated pipeline just for the skin.
A dedicated pipeline. And these perforators form these intricate connections within the skin's subdermal plexus. In plastic and reconstructive surgery, designing a surgical flap, a piece of skin and tissue moved from one site to another, depends entirely on identifying and preserving a reliable perforator. Their presence ensures the skin gets enough blood supply, even if the large axial vessels are interrupted or ligated. It just demonstrates a deep layer of vascular redundancy. It's brilliant.
It is brilliant. Okay, let's transition now to the scaffolding, the bony foundations, starting right at the root. The clavicle or the collarbone,
The strut.
the strut of the shoulder. This elegant, crank-shaped horizontal lever is often underestimated, isn't it? But it is the critical strut. It transmits all forces, pushing, pulling, carrying loads from the entire upper limb back to the axial skeleton.
And its anatomy is completely defined by this necessity for force transmission.
Yeah.
The medial two-thirds are cylindrical, and they curve convexly forward toward the sternum. The lateral third, however, is flattened, and it curves concavely forward. This double curve is what gives it that crank shape, which maximizes its mechanical advantage, but it also makes it mechanically predictable in terms of fracture risk.
Right, it creates a weak point. So if we look closely at the bone itself, which attachment points tell the story of its immense stabilizing role?
The clavicle has 4 surfaces,
Mm-hmm.
but the inferior surface is functionally the most revealing. Close to the sternal end, there's a roughened area, the impression for the costoclavicular ligament.
Which anchors it to the first rib.
Tightly. It anchors the clavicle tightly to the first rib. Then laterally, we find the critical attachment sites for the scapula suspension, the more medial conical conoid tubercle, and the lateral linear trapezoid line. These are the attachment points for the very strong coricoclavicular ligaments.
Okay.
And finally, running lengthwise is the subclavian groove, which is home to the subclavius muscle. It provides a bit of padding and protection for the neurovascular bundle that passes right underneath.
Let's dedicate some time to the clavicle's bizarre growth pattern, because it really is a complete anatomical outlier.
Oh, this is one of those fascinating details in musculoskeletal anatomy. The clavicle is the first bone in the entire body to begin ossifying.
The very first one.
The very first. Primary centers appear remarkably early, during the 5th to 6th fetal weeks, and it uses intramembranous ossification, which is typical for flat bones like the skull, not for a long bone like this.
And yet, despite starting first, it finishes dead last.
Precisely. It is the last bone in the entire human body to complete its ossification and fuse. Epiphyseal fusion at the sternal end happens incredibly late, often between 20 and 25 years of age, and sometimes even a little later in males.
So what does that mean for, say, a young athlete?
It means that young adults who are engaged in highly strenuous activities are still working with an unfused clavicle end. This has major implications for stress fractures and specialized athletic injuries.
Given that crank shape and its role as a tether, where does it fail most often? Where does it break?
Its crank shape dictates its vulnerability. The middle third is the most common fracture site because it receives both compression and bending forces.
And when a fracture happens, the muscle dynamics are, as you said, textbook.
They are. The proximal sternal fragment is powerfully displaced superiorly by the strong pull of the sternocleidomastoid muscle. It just yanks it up.
And the other piece.
Meanwhile, the lateral fragment is displaced inferiorly by the sheer weight of the unsupported limb and the tethering pull of the deltoid muscle. So you get this characteristic step deformity.
And what about dislocations at the ends of the bone?
Well, while the AC joint is frequently injured, the SC joint is incredibly strong. Dislocation of the medial, the sternal end, is relatively common following massive trauma.
And a posterior dislocation there is an emergency.
A critical emergency. Although they are usually anterior, a posterior SC joint dislocation is a huge problem, as the displaced clavicle fragment can compromise the trachea, the esophagus, or the major neurovascular structures located deep in the root of the neck.
Right. Okay, so having anchored the system with the clavicle, let's turn to the highly mobile platform it supports. The scapula.
The shoulder blade.
This large, flat, triangular bone provides the foundation for the arm, and it just glides over the posterior chest wall from about the 2nd to the 7th ribs.
The scapula's entire job is mobilization. It has 3 borders: superior, lateral, and medial. The medial border is really key to stability, as it's the thin attachment point for the rhomboids and the serratus anterior muscles we'll get into later that literally pin the scapula to the thorax.
And its angles define its functional landmarks.
Yes, and the lateral angle is the most critical feature because it houses the shallow, pear-shaped glenoid cavity.
The socket.
The socket, yes. This small concavity covered in hyaline cartilage is what articulates with the enormous humeral head. And that mismatch, a huge ball on a shallow little plate, is the structural embodiment of the stability-mobility paradox we keep talking about.
And surrounding that glenoid, you have the origins of the long muscles of the arm.
You do. The supraglenoid tubercle, which is situated superiorly, is the crucial origin for the long head of the biceps. And inferiorly, the infraglenoid tubercle provides the origin for the long head of the triceps. These tendons pass immediately adjacent to the joint, which provides another layer of dynamic stabilization.
Okay, let's discuss the prominent bony projections that give the scapula its characteristic shape.
All right, so posteriorly we have the large horizontal ridge, the spine, which terminates laterally in the broad, palpable acromion,
A peak of the shoulder.
the peak of the shoulder. And the acromion not only forms that peak, but it articulates with the clavicle at the AC joint. Then anteriorly, extending out like a bent finger, is the coracoid process.
Which means crow's beak.
It does. And this projection is a powerhouse attachment site. It anchors multiple strong ligaments, the coracoclavicular, the coracoacromial, and it provides origins for the short head of the biceps and the coracobrachialis.
And we also have to note the suprascapular notch.
We do. It's often covered by the superior transverse scapular ligament, which forms a foramen. And that foramen transmits the very vulnerable suprascapular nerve.
And the scapula's ossification is complex, right? It involves many secondary centers, reinforcing its importance as this muscular platform.
It does. While the main body ossifies early, the scapula develops with multiple secondary centers, about 7 or 8 in total, and they are concentrated at its functional margins. These include centers for the coracoid process, the acromion, the vertebral or medial border, and the inferior angle. Fusion generally completes around the late teens or early 20s, slightly earlier than the clavicle, which suggests that its peak strength and maturity align with early adulthood.
All right. Finally, for the bones, we reach the humerus, the central bone of the arm, designed to maximize the range that the scapula affords. It is the longest and largest bone of the upper limb.
Okay, let's focus intensely on the proximal end, as this really dictates the movement dynamics. The hemispherical head faces superiorly, medially, and importantly, posteriorly.
Right, it's not straight.
No. Our sources specify this backward rotation is about 30 degrees, which is known as retroversion.
Yeah.
This angle is crucial because it influences the functional arc of rotation, and it's a key consideration in prosthetic design for shoulder replacements.
And surrounding the head are those two massive landmarks for muscle attachment, the tubercles.
Yes, the greater tubercle is prominent laterally and superiorly, and it receives the insertions of 3 of the 4 rotator cuff muscles, the supraspinatus, infraspinatus, and teres minor.
Okay.
The lesser tubercle is smaller and more anterior, and it's reserved for the insertion of the powerful subscapularis.
Now we have 2 necks on the humerus, one anatomical, one surgical, with just vast clinical
A
consequence.
huge difference. The anatomical neck is the subtle groove where the joint capsule attaches. It's an anatomical landmark. The surgical neck is the crucial clinical pivot point. It's immediately distal to the tubercles, and it is the most common fracture site in the proximal humerus because it's narrower.
And the clinical risk there is severe.
It's severe because the axillary nerve and the posterior circumflex humeral vessels wrap directly around this neck. A fracture there means those structures are highly vulnerable, which can lead to immediate deltoid paralysis and sensory loss.
And the groove between the tubercles acts as a highway for an important tendon.
That's right. That is the intertubercular sulcus, or the bicipital sulcus. It houses the long head of the biceps brachitendon, which is held in place by a transverse humeral ligament, along with the ascending branch of the anterior circumflex humeral artery. The lips of this sulcus are also insertion points for the major adductors and rotators, pectoralis major, latissimus dorsi, and teres major.
Okay, moving down the shaft, the bone changes shape, and it harbors another crucial nerve pathway.
It does. The shaft transitions from being cylindrical proximally to triangular distally. Mid-laterally, you have the V-shaped deltoid tuberosity, which marks the deltoid insertion. And posteriorly, running obliquely down the shaft, is the vital radial groove.
And that's a danger zone.
A huge danger zone. It transmits the radial nerve and the profunda brachii artery. Any mid-shaft humerus fracture carries a very high risk of damaging the radial nerve at this location, leading to a loss of extensor function, the classic wrist drop.
Finally, let's just solidify the humerus ossification timeline.
Proximally, it begins with 4 primary centers that eventually fuse, one for the head and one each for the greater and lesser tubercles. Importantly, these 3 centers fuse together first, early in childhood. The proximal epiphyseal fusion happens relatively late, completing around ages 18 to 20 years in males and 16 to 17 years in females. And this fusion sequence is crucial in pediatric sports medicine, because repetitive stress before complete fusion can lead to specific growth plate injuries.
Fascinating. Okay, we've built the framework. Now let's move to the joint system itself, starting where the arm meets the axial skeleton, the sternoclavicular, or SC joint. This articulation is just fundamental.
It is arguably the most structurally robust joint in the entire upper limb complex. It's classified as a synovial, sellar, or saddle joint, but functionally it's what we call hypomobile.
Not a lot of movement.
Not a lot. And it stands alone as the only true bony articulation linking the upper limb and the pectoral girdle to the torso. Without it, there is no structural tether at all.
The articulation surfaces must be incredibly strong, then, connecting the sternum, the costal cartilage, and the clavicle.
They are. The sternal end of the clavicle articulates with the manubrium of the sternum and the first costal cartilage. The joint is encased by a dense fibrous capsule, which is heavily reinforced by the intrinsic anterior and posterior sternoclavicular ligaments. The posterior ligament is particularly strong, acting as the primary restraint against posterior displacement.
But the stabilizing MVP here is a structure that doesn't even bridge the articulating bones, which is interesting.
That is the costoclavicular ligament. It is the chief stabilizing structure. It runs inferiorly from the first rib up to the costal tubercle on the inferior surface of the clavicle. It acts as this powerful tether, limiting clavicular elevation and preventing the superior dislocation of the clavicle, which would otherwise be the natural direction of displacement under an impact.
And there's also an intra-articular disc. What mechanism does it employ to ensure stability?
The joint space is divided by a fibrocartilaginous disc, and this disc is crucial because it functions as a buffer, absorbing and transmitting heavy compressive axial forces that travel up the clavicle from the arm.
Okay, so it's a shock absorber.
It's a shock absorber, but it also prevents the clavicle from displacing medially. It acts like a safety stop against medial migration into the neck. This dual role contributes immensely to the joint's incredible resilience.
Since this is the structural root, what range of motion is actually permitted here?
Well, although it's restricted compared to the GH joint, it allows for elevation and depression up to about 45 degrees, protraction and retraction about 25 degrees, and some axial rotation. These movements, though small, are vital because they allow the scapula to fully articulate with the trunk, which facilitates the full range of overhead movement.
And the stability is paramount.
Absolutely, because deep to it, you have the trachea, the great vessels, and the entire brachial plexus.
Moving laterally from there, we find the acromioclavicular, or AC, joint, where the clavicle meets the acromion of the scapula. And this is structurally much weaker than the SC joint.
Much weaker. It's classified as a synovial plane joint, and it's characterized by small, often irregular articulating surfaces. While it may contain an incomplete intra-articular disc, anatomically, the weakness really lies in its surrounding envelope.
The sources emphasize the fragility of the capsule itself.
We do. The fibrous capsule of the AC joint is remarkably thin and weak. This joint relies almost entirely on surrounding ligaments for stability, which makes it inherently susceptible to trauma.
Which is why AC joint separations are so common.
Exactly. Often called shoulder separations, they're common following direct blows to the shoulder or falls. The joint capsule alone simply cannot resist that kind of displacement.
So we have to turn to the extra-articular ligaments for support. Which complex is the indispensable stabilizer here?
That would be the corticoclavicular ligament. It's located some distance from the joint itself, connecting the clavicle superiorly to the coracoid process inferiorly. This ligament complex is structurally the most important feature of the entire AC joint stability system.
And it has two distinct parts, doesn't it? How do the conoid and trapezoid ligaments work together?
They do. The conoid ligament is medial, and it's shaped like an inverted cone. The trapezoid ligament is lateral and quadrilateral. Together, they act like massive suspenders, literally suspending the scapula from the clavicle.
Okay.
Their primary role is to resist vertical displacement, effectively preventing the acromion from dropping away from the clavicle during an impact, which is the mechanism of a third-degree AC separation.
What are the functional movements here, then?
The movements are small, but they are absolutely non-negotiable for full arm function. The AC joint permits fine-tuning, allowing the scapula to rotate upward and downward on the clavicle, and to translate slightly anteriorly and posteriorly. These subtle movements ensure the glenoid cavity is always optimally oriented to receive the humeral head throughout the entire arc of abduction.
Especially during that critical phase of reaching overhead.
Exactly, during that critical overhead reach.
Okay, now for the showstopper. The glenohumeral joint, the shoulder joint proper, it's the definition of a synovial multiaxial spheroidal joint, the true ball and socket. And that shear scale mismatch, the large humeral head being 4 times the size of the shallow glenoid fossa, that is the structural price paid for hypermobility.
It is. Minimal static stability demands maximal dynamic compensation. So let's start with the immediate stabilizers. The glenoid labrum is a fibrocartilaginous rim that attaches to the margin of the glenoid fossa.
It's like a gasket.
It is. By wedging the socket, it deepens the articulation by about 50%, which provides some marginal static stability and, crucially, real estate for the capsule to attach to.
And the capsule itself is famously loose.
Very loose. The fibrous capsule attaches proximally to the labrum and distally to the anatomical neck of the humerus. It's relatively slack when the arm is at rest, which is what allows for the tremendous range of motion. It only achieves tautness at the extremes of movement, particularly in external rotation and abduction.
The sources mention critical openings in that capsule. What are they for?
There are two key openings. The first allows the tendon of the long head of the biceps brachii to exit, which makes that tendon intracapsular but extrasynovial. It's inside the capsule but outside the synovial membrane.
Okay.
The second, and this is clinically important, is an opening anteriorly, which allows the joint space to communicate freely with the subscapular bursa. This communication means that internal joint inflammation or an infection can easily spread to the bursa or vice versa.
Let's focus on the primary static stabilizers, the glenohumeral ligaments.
All right. The three glenohumeral ligaments, superior, middle, and inferior, are actually just thickenings of the anterior capsule. You can only really see them from inside the joint. The most significant structural restraint is the inferior glenohumeral ligament complex.
And why is that one so important?
This complex is particularly important because it is the principal restraint against anterior and inferior subluxation when the arm is placed in that vulnerable, high-risk position, abduction and external rotation. It acts like a hammock holding the humeral head.
And what about superior reinforcement?
Superiorly, you have the coracohumeral ligament. It reinforces the superior capsule. It runs from the coracoid process, and it blends deeply with the supraspinatus tendon. Its primary function is to restrict inferior and posterior translation when the arm is fully dependent or supported.
Finally, the bursae, the lubricating envelopes that prevent friction.
The key bursae are subacromial and subdeltoid bursae, which are often continuous with each other. They sit as these lubricated cushions between the rotator cuff tendons, especially the supraspinatus, and the overlying acromion and deltoid muscle.
Their function is purely facilitatory then.
Purely. They enable smooth, friction-free movement. However, they are highly prone to inflammation, or bursitis, particularly in cases of rotator cuff disease or chronic impingement, which is when the tendons rub excessively beneath the acromion.
That makes perfect sense. Okay, now we need to integrate movement, focusing on the scapulothoracic joint. As we established, this isn't a true anatomical joint, but it's a critical physiological mechanism.
That's correct. It's a gliding space, facilitated by loose connective tissue and muscle layers, specifically the serratus anterior gliding against the subscapularis. This mechanism allows the scapula to glide over the convex posterior thoracic cage, and it is entirely essential for establishing the scapulohumeral rhythm.
Right. If the platform doesn't move, the arm can't reach.
You've got it. The whole system is stuck.
Let's define the key movements of that platform.
We see translations and rotations. You have elevation, which is shrugging, and depression, dropping the shoulders. You have protraction, which is also called abduction, pulling the scapula anteriorly around the ribs.
And retraction, which is the opposite.
Retraction or adduction, pulling the scapula back toward the midline. But most importantly, you have rotation. Upward rotation is when the glenoid cavity tilts superiorly, which is necessary for lifting the arm overhead, and downward rotation is just the return movement.
So why is this rhythm so critical, and what is the precise ratio that the sources detail?
The rhythm is the synchronized movement required to prevent impingement and maximize the range of motion. The scapula has to rotate to keep the humeral head from hitting the underside of the acromion. The established ratio is that for every 3 degrees of abduction achieved by the arm, 2 degrees happen at the glenohumeral joint, and 1 degree must occur through the rotation of the scapulothoracic joint.
So a 2-to-1 ratio.
3-to-1 ratio. And it must be maintained, especially above 90 degrees of abduction.
What are the clinical consequences if this timing or coordination is off, if the rhythm is disrupted?
This failure is termed scapular dyskinesis. If the scapula fails to upwardly rotate during abduction, the space between the acromion and the humeral head narrows drastically. This relative impingement restricts the overall range of motion, it often causes pain, and it leads to chronic degenerative wear on the rotator cuff tendons, especially the supraspinatus. The entire system fails if the mobile platform isn't both stable and dynamic.
So that brings us to the muscles that control that platform. Let's start with the trapezius, the master suspender.
The trapezius is the most superficial and largest muscle of the posterior trunk that connects the axial skeleton to the shoulder. It's flat and diamond-shaped, and it originates from the skull all the way down to T12. Functionally, it acts as the primary means of suspending the entire upper limb from the trunk.
Okay, let's break down the distinct actions of its three components, starting with the upper fibers.
The upper fibers are the prime movers for elevation of the scapula. That's your classic shoulder shrug. Crucially, though, they are the strongest contributor to the superior or upward rotation of the glenoid. This specific rotation is non-negotiable for reaching above 90 degrees.
And the middle fibers?
They run horizontally, and they are the key retractors or adductors of the scapula, pulling it straight toward the vertebral column. They work constantly to brace the shoulder when you're carrying loads or performing any kind of pulling movement.
And the lower fibers, which are often overlooked in their importance.
They are. The lower fibers pull the scapula inferiorly, causing depression. However, they synergize powerfully with the upper fibers to complete that necessary superior rotation of the glenoid for a full overhead reach. Without this synchronized effort across all three sections, a full range of motion is just impossible.
What's its unique innervation, and what is the telltale sign of nerve damage?
The trapezius is innervated by the accessory nerve, which is cranial nerve XA, along with sensory fibers from the cervical plexus. Clinically, a lesion of CNASI, maybe due to surgery in the neck, results in dramatic impairment.
What does that look like?
The patient presents with a very characteristic posture. The affected scapula is dropped or depressed and pulled forward, protracted. The patient will struggle immensely to perform a shoulder shrug or lift their arm above the horizontal, which just illustrates the trapezius's vital role in superior rotation and suspension.
Moving deeper now, we find the serratus anterior, often called the boxer's muscle. It's a large muscle sheet attaching to the medial border of the scapula and then sweeping forward to attach to the first 8 or 9 ribs.
It earns the name boxer's muscle because it is the primary muscle responsible for forceful protraction or abduction of the scapula. It drives the arm forward, like during a punch or a pushing movement.
But its stabilization function is perhaps even more important than its action.
It is. That crucial stability depends on its lower fibers. They are paramount because they act as the main anchors that keep the vertebral or medial border of the scapula pressed firmly against the convexity of the thoracic cage.
So it stops it from peeling off the back.
Precisely. During an overhead reach, the serratus anterior is the antagonist that counters lateral pulling forces, ensuring the scapula rotates smoothly without peeling off the chest wall.
And the nerve supplying this muscle is famously long and vulnerable. What happens when the long thoracic nerve is damaged?
The long thoracic nerve is relatively superficial as it tracks along the ribs, which makes it susceptible to blunt trauma, surgical injury like a lymph node dissection, or even prolonged pressure from carrying heavy packs.
And palsy of this nerve results in?
The classic sign of winging of the scapula.
Yeah.
When the patient pushes against a wall or performs a forceful movement, the medial border of the scapula lifts dramatically and visibly off the chest wall. It's a clear demonstration of the loss of the serratus anterior stabilizing force.
Providing the counterpole to that are the rhomboids.
Exactly. The rhomboids major and minor are deep to the trapezius, and they connect the vertebral border of the scapula to the thoracic vertebrae, from C7 to T5. Their action is precisely antagonistic to the protractors.
So they pull the scapula back.
They powerfully retract or adduct the scapula, and significantly they cause inferior or downward rotation of the glenoid.
How do they integrate into the overall stability system?
They are powerful synergists. They work with the middle trapezius fibers for pure retraction, but they also act with the levator scapulae to fix the scapula against the chest wall when the arm is resisting a heavy load or pushing down. They provide a solid, immovable base for the arm's movement. Both rhomboids are innervated by the dorsal scapular nerve.
Okay, briefly, the levator scapulae, what is its main function?
The levator scapulae runs from the cervical vertebrae, the C1 to C4 transverse processes, down to the superior angle of the scapula. Its functions are pretty straightforward. It elevates the scapula, and it assists the rhomboids in downward rotation. It's often involved in neck and shoulder pain due to postural strain.
And its innervation?
It receives innervation from the dorsal scapular nerve and also direct cervical branches.
Now let's discuss the massive anterior trunk connectors, the pectoralis group, which dictates so much of our anterior arm power.
The pectoralis major is the dominant muscle here. It's a fan-shaped powerhouse that defines the anterior chest. With its clavicular and sternocostal heads, it's the primary adductor, pulling the arm back toward the body, and a powerful medial rotator of the humerus.
It's also a strong flexor.
A very strong flexor, especially when the arm starts from an extended position. Functionally, it's crucial for powerful movements like climbing, bench pressing, or any kind of aggressive adduction.
And the smaller, deeper pectoralis minor, what stands out about its action?
The pectoralis minor lies deep to the major. Now, unlike the major, it acts primarily on the scapula. Its role is to depress and protract the scapula and assist in slight downward rotation. The sources highlight that its main contribution is actually stabilization. It helps stabilize the scapula against the rib cage when the shoulder girdle is loaded by the upper limb's weight. It acts as a crucial inferior counterforce against the superior pull of the trapezius.
Okay, we stabilized the platform. Let's move on to the muscles acting directly on the humerus. The deltoid forms that characteristic rounded cap of the shoulder. It's a thick triangular muscle that essentially defines the structure.
It has three functional, very distinct parts: the anterior or clavicular, the lateral or acromial, and the posterior from the scapular spine. All these parts converge on the roughened deltoid tuberosity of the humerus, mid-shaft.
Its primary job is abduction, but we need to revisit that critical synergy requirement we touched on.
We do. The deltoid is the primary abductor of the arm. Specifically, the lateral head is the strongest lifter. But the sources are very clear. The deltoid only works effectively after the first 15 degrees of abduction have been initiated by the supraspinatus.
So if it fires from 0 degrees, what happens?
If the deltoid contracts forcefully from 0 degrees, it mostly just pulls the humeral head superiorly. It shunts it upward.
And the anterior and posterior components provide the directional control.
Precisely. The anterior part acts powerfully to flex and medially rotate the arm. The posterior part provides extension and lateral rotation. The integration of these three parts allows the deltoid to precisely position the arm in a full 360-degree arc around the shoulder.
What's the single most common cause of deltoid functional loss?
Damage to its sole nerve supply, the axillary nerve C5, C6. As we mentioned, this nerve is incredibly vulnerable where it wraps around the surgical neck. Injury results in rapid deltoid wasting, which is clinically visible atrophy, and the inability to abduct the arm past that initial 15 degrees.
And there's sensory loss, too.
Yes, sensory loss over the lateral shoulder, the classic regimental badge area.
Okay, let's zero in on the biomechanics of stable abduction. Why does the deltoid need its counterparts, the rotator cuff, so badly?
This is the absolute genius of the dynamic stabilization system. When the deltoid contracts, its line of pull is superiorly directed. If it were unopposed, it would drive the large humeral head straight up, slamming it into the rigid acromion,
Causing impingement.
a mechanism that causes painful impingement and eventual tear. The deltoid therefore requires the simultaneous co-contraction of the remaining rotator cuff muscles, the infraspinatus, teres minor, and especially the subscapularis.
And they pull down.
They pull the humeral head inferiorly and medially, counteracting the superior vector of the deltoid. This keeps the head perfectly centralized within the glenoid fossa throughout the entire movement. Without this synergistic counterbalance, the shoulder cannot function painlessly. It's a beautiful force couple.
So that's the perfect lead-in to the rotator cuff muscles themselves.
The rotator cuff is not a muscle group defined by its power, but by its intimate anatomical connection to the joint capsule. It comprises four muscles: sedics, supraspinatus, infraspinatus, teres minor, and subscapularis. Their tendons merge seamlessly with the glenohumeral joint capsule, forming a continuous cuff.
So their primary function isn't gross movement, but moment-to-moment fine-tuning.
Their overriding role is dynamic stability. They continually adjust tone, tension, and length to keep that large humeral head precisely centralized in the small glenoid fossa, maximizing the stability afforded by the loose-packed position.
Okay, let's detail each one, starting with the one most prone to injury, supraspinatus.
The supraspinatus arises from the supraspinous fossa and inserts superiorly on the greater tubercle. Functionally, as we said, it initiates the first 15 degrees of abduction. Because its tendon passes directly under the acromion, it is the most commonly injured and degenerative tendon in rotator cuff pathology, often through mechanical impingement.
And its nerve supply.
The suprascapular nerve, C5, C6.
Next, the two lateral rotator.
The infraspinatus originates from the infraspinous fossa, and it is the strongest lateral rotator of the arm. It's crucial for activities like throwing or serving in tennis. It shares innervation with the supraspinatus, the suprascapular nerve. Then we have the teres minor, which originates from the lateral scapular border. It's a weaker lateral rotator, and it assists in adduction. Its innervation is separate and high risk. The axillary nerve, C5, C6.
And the massive muscle covering the front of the scapula.
That's the subscapularis. It is the largest of the four cuff muscles. It arises from the entire anterior surface. the subscapular fossa, and it inserts on the lesser tubercle. It is a powerful medial rotator and adductor. It acts anteriorly to prevent posterior dislocation, and it counteracts the strong lateral rotator.
And its innervation.
It's innervated by the upper and lower subscapular nerves, C5, C7.
We must clarify a common confusion point, the teres major. Why is it consistently misclassified as part of the cuff, and why is that incorrect?
It's a great point. Teres major is structurally and functionally distinct, and it is not part of the rotator cuff. While it attaches to the inferior angle of the scapula and the medial lip of the bicipital groove, its tendon does not fuse with the joint capsule.
And that's the defining feature of a cuff muscle.
That is the defining feature. Functionally, it's grouped with the latissimus dorsi, hence the nickname Let's Little Helper. Its primary actions are powerful adduction and medial rotation. It's innervated by the lower subscapular nerve. Its exclusion from the cuff is a crucial anatomical distinction defining the dynamic stabilizers.
Okay. Moving distally now, the arm itself is structurally simpler, divided into those anterior flexor and posterior extensor compartments by the intermuscular septa.
It is. The anterior compartment houses the three primary flexors, biceps brachii, coracobrachialis, and brachialis. And they are almost entirely innervated by the musculocutaneous nerve, C5, C7.
The biceps is the most visible, defined by its two heads.
The biceps brachii is functionally complex. Its long head originates from the supraartenoid tubercle, so it's intracapsular, and its short head originates from the coracoid process. The biceps is an incredibly powerful supinator of the forearm.
Twisting the palm up.
Twisting the palm up, exactly. And it's a strong secondary flexor of the elbow. The long head tendon traveling through that bicipital groove is notoriously prone to subluxation or rupture.
And the smallest muscle, often used as an anatomical landmark.
That's the coracobrachialis. It arises from the coracoid process. It weakly adducts the arm and assists in shoulder flexion. It is most famous for being pierced by the musculocutaneous nerve as the nerve enters the anterior compartment. It's a classic landmark.
And the true workhorse of elbow flexion, regardless of the forearm's position.
That distinction belongs to the brachialis. It lies deep to the biceps and attaches broadly to the lower half of the anterior humerus, inserting firmly onto the tuberosity and coronoid process of the ulna.
And that's the key.
That's the key. Because it inserts on the ulna and bypasses the radius, its flexion action is reliable and dominant, whether the forearm is pronated, supinated, or neutral. It is the anatomical definition of the principal flexor.
All right, now switching to the back, the posterior compartment.
This compartment is dominated by one powerful single extensor, the triceps brachii. It is innervated entirely by the radial nerve, C6, C8. It has three heads. The long head originates from the infragular tubercle, which means it crosses the shoulder joint, and so it assists in shoulder extension and adduction.
And the other two heads?
The medial and lateral heads arise from the posterior humerus itself.
What is the triceps' sole mechanical responsibility at the elbow?
It is the sole extensor of the elbow joint. Its medial head is the deepest and most consistent extensor. Clinically, testing these compartments is fundamental. For example, testing the triceps is simply resisting elbow extension. Testing the biceps requires resistance to elbow flexion with the forearm supinated to maximize the biceps involvement.
Fantastic. Okay, we've built the muscular system. Now we turn to the infrastructure, the vascular and neural superhighways that sustain the entire limb.
The supply lines.
The supply lines. The main arterial pathway is a continuous trunk, but its name changes according to the geographical landmarks it passes.
That's right. The trunk begins as the subclavian artery. It officially becomes the axillary artery as soon as it passes the lateral border of the first rib. It retains the name axillary artery until it reaches the inferior border of the teres major muscle.
At which point it becomes the brachial artery.
It becomes a brachial artery which runs down the arm.
And the axillary artery's path is functionally divided into three distinct parts by its relationship to the pectoralis minor muscle. This division is crucial for surgical reference.
Absolutely. Part 1 is proximal to the pectoralis minor, and it has one branch, the superior thoracic artery. Part 2 is deep, or posterior, to the pectoralis minor, and it gives off two branches, the large, short thoracoacromial artery and the lateral thoracic artery.
And part 3, the segment distal to the pectoralis minor.
Part 3 is distal to the muscle, and it's the most prolific. It yields three major branches. First, the massive subscapular artery, which almost immediately bifurcates into the circumflex scapular artery and the thoracodorsal artery.
Okay.
Second and third are the anterior and posterior circumflex humeral arteries. These latter two are critically important as they wind around the surgical neck of the humerus, forming a vital ring of collateral circulation.
Speaking of collateral circulation, the scapular anastomosis is a critical network. Why is this collateral flow so surgically necessary, and which arteries contribute?
This anastomosis is the limb's backup power supply. If the main proximal supply, the subclavian or axillary artery, is blocked, maybe by a fracture fragment or a deep clot, this network provides a collateral route for blood flow to bypass the blockage and perfuse the arm.
So it's a natural bypass.
It's a natural bypass. It involves contributions from vessels originating before the blockage, like the dorsal scapular artery and the suprascapular artery, connecting to vessels originating after the blockage, like the circumflex scapular artery, which is a part 3 branch. This loop is what often saves the limb from ischemia following catastrophic trauma to the main arterial trunk.
Let's briefly address venous drainage and the lymphatics of the axilla.
The venous drainage is complex. It involves both deep and superficial systems. The deep system has the small vena-comitant paired deep veins that accompany the major arteries, and they eventually consolidate to form the axillary vein.
And the superficial system?
The superficial system involves the large, palpable veins beneath the skin, the cephalic vein on the lateral side, which empties into the axillary vein, and the basilic vein on the medial side, which drains into the deep brachial vein. For lymphatics, the 20 to 30 axillary lymph nodes are the body's filter system for the entire upper limb and much of the chest and back. They are meticulously grouped into 5 key categories: the pectoral, subscapular, humeral, central, and apical groups, forming a chain that must be fully assessed in conditions like breast cancer.
Okay. Finally, we arrive at the brachial plexus. This dense, complex network, originating from the ventral rami of C5 through T1, is the entire motor and sensory control center for the arm. So what does this organizational complexity, roots, trunks, divisions, cords, and branches, tell us about the nervous system's dedication to redundancy?
The complexity is entirely about reliability and redundancy. By weaving the nerve fibers together, splitting and merging through those 5 stages, a single root lesion, a high injury, affects multiple muscles and sensory areas. But the entire limb is rarely completely paralyzed unless the lesion is extremely high, like a C5-21 avulsion.
And it's in a vulnerable spot.
Very. The plexus travels deep to the clavicle, which makes it vulnerable to trauma at the root of the neck.
Focusing on the cords, their names denote their crucial relationship to the axillary artery in the armpit region.
That's right. The lateral cord, from C5-C7, yields the musculocutaneous nerve and the lateral root of the median nerve. The medial cord, from C8-T1, yields the ulnar nerve and the medial root of the median nerve, and the posterior cord, from C5-T1, yields the 2 largest nerves of the arm, the axillary nerve and the radial nerve.
Let's look at the functional impact of these terminal nerves, starting with the axillary nerve.
The axillary nerve, C5-C6, is primarily responsible for the deltoid and the teres minor. As we've discussed, its path around the surgical neck makes it vulnerable to fracture, shoulder dislocation, or deep trauma. Loss of this nerve means an inability to initiate and maintain abduction, and that sensory loss over the regimental badge area.
Next, the musculocutaneous nerve.
The musculocutaneous nerve, C5-C7, supplies all the anterior arm flexors, the biceps, brachialis, and coracobrachialis. Injury here profoundly weakens elbow flexion power, but the biggest motor loss is actually supination power. It severely limits the ability to turn the palm up, especially against resistance.
And its sensory component.
Its sensory contribution is the lateral cutaneous nerve of the forearm.
The median nerve has a very long path through the arm without many initial branches.
It does. The median nerve, C6-T1, is formed by its lateral and medial roots wrapping around the axillary artery. It travels down the arm alongside the brachial artery, crossing anteriorly, usually around the elbow. It gives off virtually no motor branches in the arm itself. Its vulnerability in the arm is low, but its critical motor and sensory roles begin distally, especially in the forearm flexors and most of the intrinsic thumb muscles.
And the ulnar nerve is notorious for its path at the elbow.
It is. The ulnar nerve, C8-T1, courses medially down the arm, but then it takes a distinctive vulnerable detour. It passes posteriorly around the medial epicondyle of the humerus, where it lies exposed in the cubital tunnel, the funny bone.
Right.
Trauma there causes that immediate tingling and pain. Like the median nerve, its primary motor function is distal, supplying crucial intrinsic hand muscles and sensation to the medial hand.
Finally, the largest nerve of the arm, the extensor control center, the radial nerve.
The radial nerve, C5-T1, stemming from the posterior cord, is the extensor powerhouse. It supplies the triceps and all of the forearm extensors. Its major vulnerability, as we said, is in the radial groove of the humerus shaft. Fractures there, or deep compression like Saturday night palsy, from falling asleep with your arm over a chair can cause severe injury.
And the classic clinical sign of radial nerve palsy.
It's the complete loss of wrist and finger extension, which is known as wrist drop.
This has been an incredibly detailed journey through the nervous system's master plan.
It truly has.
We began this deep dive with the paradox of the upper limb, the need for precision and reach built upon a structurally weak joint. We've meticulously explored how every structure, from that late fusing clavicle transmitting forces to the complex interwoven redundancy of the brachial plexus, is engineered to manage that paradox. The synthesis reveals that the upper limb is a machine optimized for dynamic function over static stability.
That dynamic optimization is the primary takeaway. The scapulohumeral rhythm, that precise 2.1 coordination, is entirely dependent on the synchronized, co-contracting forces of the rotator cuff muscles, which must fire constantly to centralize the humeral head.
It's all connected.
The system is so interdependent that the failure of a single, seemingly minor nerve, like the long thoracic, can destroy the entire mobile platform through scapular winging. It renders the powerful deltoid muscle useless for stable overhead movement. It is a stunning example of how coordination outweighs raw strength.
The lesson for us as learners is profound. Whenever an anatomical design prioritizes hypermobility, as the glenohumeral joint does with its loose capsule and mismatched surfaces, the cost is immediately paid by requiring dynamic stabilization. It demands constant active muscular compensation.
A mechanism of perpetual dynamic tension.
Which leaves us with this final thought for you to explore. We have seen how biology solved the problem of balancing hypermobility with dynamic stability using the rotator cuff as a set of compensating forces. Now, consider the world of non-biological engineering. What complex mechanical systems, perhaps in advanced robotics, drone stabilization, or even deep-sea manipulator arms, use a similar principle of dynamic stabilization, where the joints themselves are inherently weak but rely on continuous synchronized actuator control to maintain operational stability across a massive range of motion? Something to mull over until our next deep dive.